my pathology, I did ankylosing spondylitis, and you want to do I'm going to do 2 lumbar projections, the AP and the lateral, to show the pathology, which would first start in the lumbar spine, so that's why I'm doing that. First, I would get the patient and obtain 2 patient identifiers, their name and their date of birth, and then I would have the patient go get dressed, removing everything except for lower undergarments and just putting on a hospital gown. And then after that, I would have them come in and I would ask them a little bit of history. I would ask if they're having any pain, where's their pain located at, if the pain's going down either or both their legs, if the patient has any back surgeries, and also when did everything start occurring. And also, if it's a female patient, you want to make sure and ask when their last menstrual period was, and if there's any chance of pregnancy. Alright, to get started, I'm going to have the patient lay down flat, supine on the table, have their knees bent, which will just flatten out the curvature of the spine so that it's parallel to the IR. And then I'm going to have a lap shield placed just to cover the gonads from any radiation. And put a 14 by 17 lengthwise cassette into the Bucky tray, and I will have a right marker on the right side, which I put that in 3 inches approximately from the edge of the image receptor for collimating purposes. And next, I am going to go ahead, since my tube is already at 40 inches and in transverse detent and lined up to my IR, I'm going to palpate her ASIS and follow down to her iliac crest, which will be the central, where you want the centering point for this projection, which that looks good. I am going to palpate both of her ASISs to ensure that there is no rotation of her pelvis. And also for the centering point, I'm going to come up here and make sure that she's aligned, and again feel her ASISs, and midway between that is where you want the centering point to also lie, which that looks good. Make sure that our arms are down by her side, and next I am going to just measure in the path of the central ray, so I'll lift her arm out of the way here. And she measures about a 19, and then I'm going to step out of the room, set my exposure factors, and instruct her on some breathing instructions, which for this would be suspended expiration to move the diaphragm up and out of the way of the lumbar spine. Okay, next I am going to come in and I will have her turn on her left side away from me. And I'm just going to place this over her lock again, which I can adjust later. I'm going to ensure that she's in a true lateral position aligned with the IR, and I'm going to have her move her hips forward for me so that she's more in the center of the table. And I'm going to bring her shoulders back just a little bit, and I'm going to make sure that both of her arms are up on top of each other in prayer position, and both of her legs are perfectly on top of each other. I am going to place a sponge in between her knees to ensure that there is no rotation of the pelvis, which is more common to happen if you don't have the sponge in females because of the wider hips. I'm going to make sure that both of her shoulders are on top of each other and her hips are on top of one another in a true lateral position. I'm going to take this hand sponge and kind of compress it and lift her side up and just put that under. This way the spine is parallel to the image receptor, that way it doesn't dip down, which the sponge helps with that. I am going to switch out my image receptor. I'm going to take the right marker and I'm going to take the left marker and put it about 3 inches in, and it will be in anterior to my patient. And I am going to then again center at the iliac crest right here. And also you want it at the level of the mid-coronal plane, which you can do that by taking your hand like this and putting it over the iliac crest, and right here will be the mid-coronal plane is a pretty good judgment of that. So do that, it looks pretty good. Just a tad. And then after that, I'm gonna have my collimation open to the full 17 inches, and I'm gonna collimate down to about a 7 to 8 inches crosswise.
Go.
Next, I'm going to take some lead matting to put behind my patient. This will just gather any extra radiation so that it doesn't go straight down to the IR, distorting the beam, and you want to just put this so that it is just getting the shadow of the back of the patient and going along with the curvature of her spine. And next, I'm just going to take my calipers and measure the patient again through the path of the central ray, which is about a 26. And then again, I would go out and set my exposure factors and tell her breathing instructions, which are again to blow her breath all the way out and hold it out to bring the diaphragm above her lumbar spine.